Good morning. Okay, let me begin by extending our heartfelt gratitude to the Philippine Social Science Council and the family of Dr. Loretta Makasiar Sicat for the LMS Prize Award. Thank you for this worthy endeavor of providing recognition to outstanding research of Filipino graduate students in the field of social sciences. So today it is my distinct pleasure to introduce the awardee and our featured speaker, Miss Denise Hyacinth Joy B. Musni. As her thesis advisor, it is truly an honor to witness her academic journey in UP culminate in this momentous occasion. Denise first embarked on her academic journey at the University of the Philippines, Manila, where she earned her bachelor's degree in political science, cum laude. Amidst the demands of her undergraduate studies, she actively participated as both an officer and member in various environmental, social-civic, youth, and academic organizations. Her phenomenological study on indigenous Bajaus was recognized as the third best thesis during the 2016 UP Manila Political Science Convocation, marking the beginning of her award-winning research streak. She later crossed to the Diliman campus of UP for her graduate studies, pursuing a Master of Arts in Demography at the Population Institute, College of Social Sciences and Philosophy. I need to mention that kasi nandiyan si Dean. Okay. During her stint at UPPI, Denise was a recipient of the UPPI Academic Excellence Award for 2 consecutive semesters, a feat that is still unparalleled to this day. She was also one of the select participants in the study exchange program between UPPI and Namur University, where she stayed for 5 months in Belgium, primarily to complete the manuscript of her master's thesis. She apparently fell in love with Belgium. Oh, she apparently fell in love with Belgium, no? With Belgium, that she decided to pursue her doctoral studies in demography at the Université Catholique de Louvain. I hope I pronounced it correctly. So also in Belgium. Actually, she flew in from Brussels just last Monday specifically for this occasion. Prior to her doctoral studies, Denise was actively involved in advocacy work and policy research at the Asian NGO Coalition for Agrarian Reform and Rural Development, where she rose from project officer to deputy executive director. But beyond her academic and professional pursuits, Denise has also lent her voice and talent as a performing member of the UP Concert Chorus for 4 years. And if her recent social media updates are any indication, she has also taken an interest in pole dancing. So who knows? Maybe we can convince her to grace us with a song or show us her pole dancing skills after her presentation later on. Wala nga lang pole dito. But seriously, Denise is among the young cohort of demographers whom we anticipate will assume leadership roles at the UP Population Institute in the years ahead. Fingers crossed. Pressure, Denise. Okay, so succeeding the current aging roster of demographers in the country. Okay, now let's talk about her thesis. Throughout the 4 years that it took her to complete her thesis, sorry Denise kung binuko kita, but to her credit, 5 months lang naman ang duration between her zero draft and thesis defense. Okay, I have been consistently impressed by her unwavering dedication, her intellectual curiosity, and exceptional work ethic. And during the final stages of her thesis writing, I was battling some serious health challenges. And despite the fog that occasionally clouded my mind during that period, Denise was able to easily comprehend and execute my instructions, demonstrating not only her profound understanding of her research topic and methodology, but also her remarkable adaptability and empathy. Okay, Denise's thesis, which examined the discontinuity between antenatal care and facility-based delivery among Filipino women, was nominated by UPPI primarily because it showcases a high level of methodological rigor using quantitative research techniques and robust statistical analysis. But more importantly, her study goes beyond academic inquiry and has considerable potential to influence the implementation of the country's maternal health care program. Denise's study is of utmost significance as it delves into a pressing social and public health concern and enriches our understanding of maternal health and the challenges faced by Filipino mothers in accessing and utilizing healthcare services. And by integrating insights from various disciplines, demography, sociology, economics, and public health, Denise's study also exemplifies the interdisciplinary nature of the field of social sciences. So, ladies and gentlemen, I invite you all to join me in welcoming Miss Denise Hyacinth Joy B. Musni as she presents her award-winning research entitled Mind the Gap, an analysis of the discontinuity between antenatal care and facility-based delivery among Filipino mothers. Thank you.
Okay, now we have time to chill a bit. This is a pretty long lecture. I was told I have 45 minutes. And I would like to start with some messages of gratitude. Of course, thank you very much to Mom Baby for the, where is Mom Baby? For the very kind and generous and very warm introduction. Thank you also to Dean Lusterio Rico and Professor Gerardo Sicat for the congratulatory message. A pleasant morning to everyone, first and foremost. To Professor Gerardo Sicat, Miss Michelle Sicat Powell, members of the Sicat family, Dr. Lourdes Portus, and the Philippine Social Science Council, thank you very much for this amazing honor. My gratitude also goes to, of course, the UP Population Institute, the College of Social Sciences and Philosophy in UP Diliman, especially my thesis advisor, Ma'am Baby, for the support in the completion of this work. The writing of my thesis was also supported by the Erasmus Plus agreement between the Population Institute and the University of Namur in Belgium. Special mention and thanks to my former UP Manila political science professors in the audience today, Ma'am Claire Berha and Sir Carl Ramota, current UP faculty regent. And of course, my deep gratitude goes to my family and friends for their constant support and love. The MC today is my dear friend, Ryan. It feels surreal to deliver this presentation in person. I defended my thesis online, and it's been more than a year since I was last in the Philippines. So being in front of everyone here today feels different, to say the least. Today, I'm humbled to present to you a summary of my master's thesis with a very long title that I will not repeat because it has been repeated several times already. So, next. Despite the cute template that I selected for this PowerPoint, the background of this research is the grim reality that many Filipino women die in an attempt to bring forth life. In Filipino, we say that during childbirth, women have one foot in the grave or isang pa sa hukay, since a quarter of maternal deaths occur during labor, delivery, and in the immediate moments following childbirth. According to numbers of the Philippine Statistics Authority, around 2,000 Filipino women die yearly from pregnancy and childbirth. So that's around 4 to 7 deaths per day. Further, these numbers reflect only registered maternal deaths And we know that these deaths are underreported. In the graph on the right, we see just how persistent these figures are through the years, and we even observe a spike in the deaths in the years following the COVID-19 pandemic. The Philippines also lags behind its neighbors in tackling maternal mortality. We are slower in bringing down maternal mortality ratio, as shown by these pink bars. And we have more maternal deaths compared to nearby countries in Asia and the Pacific. It must be noted that estimates by the United Nations for maternal mortality have changed between 2019 and 2023 because of methodological considerations. But what's consistent is that more mothers are dying in the Philippines than in neighboring countries. According to the Department of Health in 2009, the country's high maternal mortality rate is due to the prevalence of home births assisted by traditional birth attendants, or TBAs. But it also bears merit to mention that at this time, they cited the 2003 National Demographic and Health Survey, which reported that 61% of births were delivered at home, and things have now changed considerably. There are global and national recommendations on maternal health care to reduce maternal and child mortality, which we can plot here on a continuum. These recommendations, it's not showing? Yes. These recommendations include receiving proper timed antenatal care, or ANC for short, also called prenatal care, having at least 4 antenatal contacts according to the Department of Health, and at least 8 according to the World Health Organization, and giving birth in a health facility, facility-based delivery, or FBD. The Department of Health also has a policy that elaborates on these recommendations, infamously referred to as the no home birthing policy. And in this research, we will focus on the recommendations to receive antenatal care and to deliver in a health facility. I might talk a lot in acronyms, so please forgive me if I just say ANC for antenatal care and FBD for facility-based delivery. As you may know, the no home birthing policy of the DOH is quite a controversial one. Because of reasons related to access to services, infrastructure, and culture. And as you may imagine, the difficulties in accessing health facilities had been exacerbated during the pandemic. Going back to the continuum that I showed earlier, according to the 2017 National Demographic and Health Survey, almost all pregnant mothers are able to have at least one antenatal care contact from a skilled provider. So that means doctors, nurses, health providers, etc. But many are not able to have the recommended 4 prenatal checkups, and even less are able to deliver in a health facility. Women drop out of the safe motherhood continuum, and this research seeks to understand why. This brings us to the research question. What factors determine facility-based delivery among mothers who have already gone to a health facility to have at least one antenatal care contact, or ANC-seeking mothers? Quickly going over some literature, it is established that sufficient antenatal care is key to safe pregnancies. Through antenatal care, pregnancy complications are detected, addressed, or prevented. Inadequate antenatal care is linked to preterm births, stillbirths, and perinatal mortality. Research in other countries, particularly African countries, found that increasing the frequency of antenatal contacts is associated with a greater likelihood of facility-based delivery. Proper timing of first visit, provision of useful information, advice to seek facility services, and number of services received have also been linked to facility-based delivery. According to Gabrish and Campbell, the determinants of skilled birth attendance may be grouped according to socio-demographic factors, perceived benefit or need for skilled birth attendance, economic accessibility, and physical accessibility. Similarly, utilization of other maternal health care services are associated with mothers' socio-demographic characteristics, distance to health facilities, health insurance, mothers' decision-making, perceived need for health services, and information available to mothers. Thus, as inspired by Gabrish and Campbell's framework, this study posits that facility-based delivery among ANC-seeking mothers is associated with the standard set of socioeconomic variables mentioned earlier: socio-demographic factors, perceived need, economic accessibility, physical accessibility. But in addition to these characteristics of antenatal care that the mother received are also hypothesized to play a role in facility-based delivery. In essence, the study hypothesizes that being able to receive antenatal care services that are appropriate and of good quality is linked to greater likelihood of delivering in a health facility. This study uses data from the 2017 National Demographic and Health Survey, the NDHS, which is a nationally representative survey participated in by over 25,000 women aged 15 to 49 years. The analytic sample includes over 6,000 married or cohabiting women who have delivered a live birth in the 5 years preceding the survey date, who were at least 20 years old during their latest birth, and who have had at least one ANC checkup during her most recent pregnancy. The outcome variable is the binary variable on the place of delivery for the mother's most recent birth. So health facility includes hospitals, clinics, NGOs, local health centers, and barangay supply service points, while non-health facility includes woman's home, another person's home, and other undisclosed locations. This is the list of independent variables that I used. Women's characteristics at the time of the survey are assumed to be the same at the time of birth, and it is an important limitation of analyzing cross-sectional data, except for the two variables that were adjusted for the timing of the birth: mother's age at the time of her latest birth, and membership in the Pantawid Pamilyang Filipino program at the time of birth. In the interest of time, I won't be reading through all of these variables. I'd like to mention, however, the variables under characteristics of ANC that I looked into: number of ANC contacts, timing of first contact, number of ANC services received, and we're talking here about the basic required services like taking the mother's blood pressure, urine test, blood test, weight measurement, and height measurement, receiving advice on complications and being told where to go in case of complications, receiving anti-tetanus shots, having iron tablets with folic, and having medicine to expel intestinal parasites. All these are variables that are in the National Demographic and Health Surveys that can be followed up through the years. And all these are based on existing recommendations on antenatal care articulated in the Department of Health's administrative orders. This study uses several analytic techniques which sound very fancy but are conceptually simple. So when I presented my master's thesis, when I defended my master's thesis, my family was there and they told me that this part sounded like gibberish to them. And so I will give a quick description of the methods for any students that may be in the online audience, and also so as not to alienate anyone from the technicalities. So univariate analysis involves observing the distribution and characteristics of one variable at a time. For instance, when we break down ANC-seeking women's educational attainment, when we look at how many of them have high education, low education, etc., that is a form of univariate analysis. Bivariate analysis, on the other hand, is looking at how one variable is related to another. So for example, going back to the education example, if we try to see how having high education is related to delivering in a health facility, That's bivariate analysis. And we have some statistical tests to see if these relationships have statistical significance or if they were just produced by chance. Multivariate analysis takes the analysis a step even further, and it is checking to see if the bivariate relationships we found earlier still exist when you take into account the other things that can affect your result. The result here is being able to deliver in a health facility. Because in real life, we know that, for example, it's not just education that affects decision-making. Multivariate analysis is also checking to see how the different chosen variables are related to the outcome that we are studying. Hence, we had that framework earlier that includes all the different variables, and they come in together in the multivariate analysis. So for the multivariate analysis, 3 binary logistic regression models were generated. Binary logistic regression is a technique used to see the relationship between variables, predictor variables, and a binary outcome. And in this situation, the binary outcome is being able to deliver in a health facility or not being able to do so. So binary because 2. So in these models, we're looking into how variables are related to the 2 possible outcomes. The first model, if it works, yes. The first model is what I call the standard FBD model, which takes into account the first 4 sets of variables in the framework set of variables and how they are linked to facility-based delivery. The second model is the enhanced FBD model, which looks at how ANC characteristics are linked to facility-based delivery once other factors in the framework are controlled for. So this step basically aims to isolate the relationship between antenatal care and facility-based delivery. I also have a third model that takes the analysis a step further by looking at the factors associated with facility-based delivery only among women who have already met the minimum required for antenatal care checkups. Limitations of the research are important to disclose and help us contextualize the findings. And an inherent limitation of analyzing the NDHS is that the data is cross-sectional, as I mentioned earlier. So unless there are ways to adjust for timing, we're looking at characteristics of women in our sample at just one point in time, which is the time of the survey. For example, PhilHealth membership and completed education can only be captured in the dataset at the time of the survey and not during the birth that may have happened 5 years ago. Yet we still assume that characteristics are the same because this is the data that we have available. There is also heavy reliance on self-reported retrospective information in the NDHS, meaning the women were asked to remember whether they had antenatal care, when they started the antenatal care, with whom, for a birth that, again, may have happened 5 years ago or just last year. And this is subject to recall bias. Women might forget what actually took place. And finally, the study could not include supply-side indicators such as the woman's actual distance to the nearest health facility or quality of equipment. Now, moving on to the key findings. We start with the profile of ANC-seeking women. Remember that when we speak of ANC-seeking women, we talk of women who have already had at least one antenatal care checkup. 90% of these mothers were able to have 4 or more prenatal checkups during their last pregnancy, and on average, these mothers had 7 antenatal care contacts. From the 90% figure, only 82% of mothers were able to deliver in a health facility. And among women with at least 4 antenatal care contacts, just 84% had facility-based delivery. Most of the ANC-seeking women, about 57%, were below 30 years old at the time of their latest live birth, still considered part of the youth. Many were in the peak childbearing age group of 25 to 29 years old, and most of the women were formally married during the survey, though many, 35%, were cohabiting with partners. Over half of ANC-seeking women have settled in rural areas. This group of women is moderately educated. More than half, 51%, attended up to high school, and a substantial percentage, 1/3, 33%, reached college. Despite this, nearly half of these mothers belong to the poorest or poorer households. Majority of these mothers are able to get benefits from the government's health insurance program, PhilHealth. A word of caution, though, in this study, it is assumed that women who belong to households with at least one PhilHealth beneficiary are also PhilHealth beneficiaries themselves. And the study does not distinguish between types of PhilHealth beneficiaries, because you can either be a beneficiary through the formal sector, informal sector, because you are an indigent, etc. Now, there are two key findings that I wish to emphasize. The first is this. Controlling for other factors, we see that antenatal care characteristics are associated with facility-based delivery. So here we are first focusing on this box here. After performing bivariate analysis on each of these ANC characteristics, we see statistically significant relationships with facility-based delivery. Some of these ANC characteristics remained significant in the multivariate analysis. Once antenatal care characteristics were added to the regression model with all the other standard variables, we observed the following. For every additional increase in the number of ANC contacts, the odds of facility-based delivery also increases by 18%. And for every additional ANC service that the woman received, again, remember, we are talking here of just the basic services, their odds of delivering in a health facility increases by 32%. Now, this may reflect the trust and comfort with the health system that some women may develop with subsequent ANC visits when they are able to receive adequate care. Some literature has also mentioned that health workers are able to encourage women to deliver in health facilities during their ANC visits. But of course, this may also just reflect women who have access to good antenatal care facilities, who would most likely have access to good birthing facilities as well. And compared with not having adequate anti-tetanus shots, having 2 or more anti-tetanus shots considered being adequately protected against tetanus is found to decrease the odds of delivering in a health facility. It's a bit counterintuitive at first, but then it is possible that the protection given by the vaccine provides mothers with more confidence to deliver outside of a health facility, knowing that the risk of infection for her and the baby has been greatly reduced. Being told to look out for complications and being advised on where to go when complications arise is also associated with a reduction in the likelihood of delivering in a health facility. The finding is more counterintuitive than the other and warrants further study, but if I were to throw a guess, it could be that there are women who prefer to entrust their pregnancies to people they know to people whom they know or are more comfortable with, be that a traditional birth attendant or a relative, if they are aware anyway of where to go in case complications arise. Let's graph these results in what's called a forest plot to visualize better. The graph only contains selected variables with statistically significant relationship with facility-based delivery. So to help anyone who might not be familiar with analyzing forest plots, the point is that if the little dots and the lines cross this middle line right here, the relationship between the variables and our outcome of interest, which is facility-based delivery, is not statistically significant. And as I mentioned earlier, this plot, I only included the variables that were statistically significant. When the little dots and the little lines go to the right of the middle line, it means that these increase the likelihood of facility-based delivery. Whereas if the dots go to the left, this decreases the likelihood of facility-based delivery. So again, we see, and also the further that the dots go from the middle line, the stronger the relationship is between the variables of interest and our outcome variable. Here we see that increasing ANC services and increasing ANC visits is associated with an increase in facility-based delivery, and their effects are quite strong. And here we see also the negative effects of having had 2 anti-tetanus shots, the reference being not being able to receive these shots, and being advised on complications and where to go when complications arise. Some statistical tests were also conducted on the models. We find here that the regression model containing ANC characteristics, so remember we took the standard variables, socio-demographic variables, and then we added characteristics of ANC, and that full model I called the enhanced model, and that model fits the data better than the model without ANC characteristics. And this supports the claim that antenatal care is an important variable when estimating the likelihood of delivering in a health facility. Going further with the forest plot, this other forest plot shows the partial results of the third model. Remember that in the third model, we restricted the sample to women who had the minimum 4 antenatal care contacts. So they're already there. They're already on the way to having more antenatal care contacts and delivering in a health facility. And here we see similar patterns. Higher frequency of antenatal care contacts and receiving more antenatal care services, in pink here, are linked to higher odds of facility-based delivery, while being adequately vaccinated against tetanus, as compared to not being vaccinated, is linked to less odds of delivery in a health facility. As a check, I checked to see if the variables are strongly correlated with one another. And I did not find any strong correlations between the independent variables that I used. And we also have a low variance inflation factor, which basically just means that each variable gives us unique information that don't duplicate what the other variables already provide. And this again strengthens the case for adding antenatal care characteristics in our independent variable risk list. The second key finding confirms what previous research has already found. Education and financial capacity are among the top factors linked to utilization of maternal healthcare services. And we also know that in many cases, education and wealth reinforce one another. So first, to see the gap between antenatal care and facility-based delivery, I looked at the percentage difference between the two. So it's just subtraction. And this table presents the groups of mothers with the lowest percentage difference between having 4 or more antenatal care contacts and delivering in a health facility. At the top of the list are mothers belonging to the richest wealth quintile. Just after mothers from NCR are mothers and their partners with higher education. These are the groups of women who consistently access health facility services, from antenatal care to delivering in a health facility. Mother's education, partner's education, and wealth quintile remained significantly associated with facility-based delivery across all the 3 regression models. In addition, being a beneficiary of PhilHealth also retained its significance in all 3 models, alluding to how subsidized healthcare services encourage their utilization. Birth order is also consistently up there. It just bears merit to mention, as it is well established in literature that later order births are less likely to be delivered in health facilities, and first-time mothers who lack childbirth experience are, unsurprisingly, more likely to deliver in health facilities. And this remains an important finding. This table is a bit of a more technical version of the Venn diagram shown earlier. So the 5 consistent variables are emphasized here in pink. But again, I would like to highlight the relationships between education, financial capacity, and facility-based delivery. So I will focus here on the variables with the pink stars. We see here that for every increase in mother's years of education, the odds of delivering in a health facility also increases by 8 to 9%. Similarly, increasing her partner's education for every additional increase in the year of education increases the odds of facility-based delivery by 4 to 6%. And we see a strong relationship between facility-based delivery and wealth quintile. for every increase in wealth quintile classification, so that goes from belonging to poorest households, poorer, middle, richer, and richest, the odds of delivering in a health facility also increases by 17 to 22%. And finally, compared to non-beneficiaries, having any form of PhilHealth benefits is strongly associated with an increase in the odds of facility-based delivery. Now, coming down to the last stretch of these presentation, here are the key takeaways and some recommendations from the results. We observed that increasing the number of ANC contacts and the services received during antenatal care is correlated with increased odds of delivering in a health facility. First, this implies that more frequent antenatal care contacts functions as an indicator of women's access to facility-based delivery, meaning in real-world settings, since a mother is, of course, first pregnant and going to health facilities to have her checkups before giving birth, and almost all women have had at least one antenatal care contact, there is then a unique opportunity to see if women will be able to deliver in a health facility just by looking at how often they are able to have prenatal checkups, and of course, if they are on time. Thus, appropriate interventions on enhancing access to and referrals to facility-based delivery may take place during the antenatal care visits. The relationship between antenatal care services and facility-based delivery then suggests that antenatal care quality also plays an important role in health service utilization. Perhaps mothers are able to put more trust in doctors and facilities if they've had positive experiences during their prenatal checkups. Perhaps having multiple services, the basic services performed during the antenatal care gives them the impression that pregnancies are being monitored properly. And these study findings imply the need to make comprehensive maternal health care services more accessible, since these services are linked with one another. Now, more on access. In the context of a commodified healthcare system, education and financial capacity, including having health insurance, are key to greater uptake of maternal health care services. Again, it could very well be the case that ANC characteristics are linked to facility-based delivery, precisely because women who have high income and high education are those who are able to access good quality antenatal care consistently. There might be some selection in these results. Pregnancy and childbirth are known to be expensive, and though more affordable services may be accessed from public hospitals, these facilities are not in the best condition, to put things lightly. Equipment are inadequate, healthcare workers are overworked, and patients have to line up for hours. Overcrowding is then unavoidable. The maternity ward of the Fabella Hospital in Manila alone, seen in the picture on the right here, the green picture, sees an average of 60 deliveries per day, with 3 mothers sharing one bed. So sometimes, maybe giving birth at home just feels safer on top of being cheaper. No mother would want to go through hellish conditions just to meet government recommendations on their place of birth. And finally, health insurance encourages maternal healthcare service utilization, which was expected and speaks to the importance of minimizing out-of-pocket expenses if we want more people to engage in formal healthcare facilities. In addition to the Universal Healthcare Act, PhilHealth has maternity packages covering prenatal, delivery, and postnatal services. And these are good things. But obviously, we still have a lot to work on when it comes to improving healthcare in the country. To show you just how much more we need to improve on, here's a sidebar with some figures. According to a DOH executive in 2021, half of the Filipino population needs to travel more than 30 minutes to get to the nearest primary healthcare facility, and only 1.2 beds are available for every 1,000 Filipinos, said to be comparable to the bed density of the poorest countries in the world. Healthcare, especially private healthcare, is still undeniably expensive and becoming more expensive. And the World Health Organization estimates that nearly half of health expenses in the country are out of Filipinos' pockets. When I was an undergrad in UP Manila, I saw the Philippine General Hospital every day. And I understood there that quality healthcare in the Philippines is a luxury, and true universal healthcare remains a dream for now. So the recommendations start with a call for government to end its preoccupation with banning home births. To ensure safe pregnancies, interventions in maternal health care should be comprehensive, directed towards improving the uptake of antenatal care and the quality of antenatal care services, on top of encouraging or forcing facility-based delivery. There should be a way to bring antenatal care services into the homes of pregnant mothers, especially for those residing in far-flung areas. The Department of Health must also adopt the updated WHO guidelines, which recommend a minimum of 8 instead of 4 antenatal care contacts. The World Health Organization updated its recommendations because of evidence that linked higher number of ANC contacts with less morbidity and mortality for mothers and their babies. The 4 antenatal care contact model that the Department of Health is implementing is a bit outdated, as it is from 2002. Next, government must increase subsidies for maternal health care services, improve the utilization of PhilHealth's maternity packages, and address the many supply-side issues of our country's healthcare system. Noting the country's terrain, especially in rural areas, and the fact that facility-based delivery goes against cultural practices of some groups, for example, indigenous peoples, the medical community, the academe, and government must also begin to consider how we can make out-of-facility deliveries safer. Now for some research recommendations. Future research may delve further into how quality antenatal care is linked to facility-based delivery. More precisely, what is it with women's antenatal care experience that maybe makes or breaks a woman's decision to deliver in a health facility? A deeper dive may also be done into how actual distance to facilities, how one's culture or religion, perceptions towards health facilities or providers affect utilization of healthcare services. We know that indigenous groups and Muslim women have an aversion to bodily exposure to strangers, even if they are healthcare workers, and these are rooted in their culture. Making matters more complicated, these populations are also physically situated in areas farther from health facilities. And some context-specific differentials may also be further explored. For example, single women, young women, mothers expecting multiple births, and first-time mothers might all have different experiences, and story might completely be different from the general story provided here. Future researchers of maternal health are highly encouraged to use mixed methods. It's a dream of every social science researcher to do this. And of course, we're basing here on quantitative data. And again, with the many limitations of quantitative data, mixed methods is really a great way to further delve into what the study scratched the surface on. And that is it. Thank you very much for your attention. I hope that wasn't too long. The references I use are too numerous to include in the slides, but I compiled them on a Google Doc accessible via this QR code. And that's it. Thank you.